has less patients. And prostration. Prostration means inability to walk or to even to sit up unsupported. So I particularly am impressed by that particular sign of prostration. A big child suddenly unable to sit up, unable to walk, and getting sick rapidly. And that is what you find at the acute care unit of Soroti Regional Referral Hospital and elsewhere where that condition presents often. Abdominal tenderness, apart from abdominal pain, tenderness is also a very troublesome symptom. And these people had about 10% of the patients presenting with abdominal tenderness. Splenomegaly, almost the same percentage. Hepatomegaly, a little less, that's 6.9. And point number 3 on that slide is that cases were more in the second half of the year, that is with a peak between July and September, giving those 3 months were responsible for 41.1% of the patients. They were treated with antimalarials, parenteral artesunate, but were also given antibiotics in about half of the patients, mainly ceftriaxone. Up to 34% of patients received blood transfusion. So you can see this blood transfusion rate is very high. And one of the things we must note is the high rate of blood transfusion that this condition needs. And I want us to remember to thank the people of the Uganda Blood Transfusion Services. They do a lot of excellent work to try to help these children with Blackwater fever survive. Steroids were given in 31.3% of the patients, mainly hydrocortisone. And the authors note that locally, there were no treatment guidelines for Blackwater fever. Next, please. Study number 3 is still Percy, Indila, Okello, and Professor Lupot. And they looked at predictors of prolonged hospitalization and mortality among children admitted with Blackwater fever in Eastern Uganda. This I got as a poster from the ResearchGate forum, and you can access it as well. The aim of this study was to determine clinical factors which would be associated with prolonged hospitalization and death among hospitalized children with Blackwater fever in Eastern Uganda. To them, prolonged hospitalization was more than 5 days. And what were the results? 1,308 children with Blackwater fever were examined. 920 of them, that is 70%, had complete records. This is, of course, a problem with the retrospective studies. Some of the records are not complete, so you drop some of the cases. So out of those, data was complete in 920. and then 250 of those had prolonged hospitalization, and that is 27%. Almost a third of the children had prolonged hospitalization. That is important because it, at least for the hospital, it means you've got to spend a lot more when a patient stays in the hospital for a prolonged period, including the cost of congestion, which is cross-infection and many other issues. But the median days of hospitalization was, the median was 3 days for those who did not have prolonged hospitalization. Which factors were independently associated with prolonged hospitalization? If the child came with abdominal tenderness, there was a significant association with prolonged hospitalization. If the child particularly had a lot of pain, seemed to be in much pain, or indeed if the child just had low-grade fever, these were the factors they found as associated with prolonged hospitalization. Now, abdominal tenderness has differentials, but one of the differentials that I have found is actually peptic ulcer disease, because the abdominal pain is often epigastric, and it is almost certain that such children who have abdominal pain and vomiting will have raised serum urea and creatinine. So it is often gastritis, uremic gastritis. But of course, in this study, they did not try to link that abdominal pain with uremic gastritis. Next, please. So what about deaths? The overall case fatality rate in this study was 3.2. That is quite low. I mean, at least appears low for such a serious condition. And if anybody has to thank a site like Soroti Regional Referral Hospital Pediatrics, that should be one of the points. They have made a lot of children survive Blackwater fever. When I came to Soroti in 3 years ago, the drama that I found was really impressive. And that time, unfortunately, there was a sit-down strike of doctors, and we had only nurses who were seeing patients, and they just had 2 things they would do, or 3. They would transfuse the child as a matter of emergency, and then they would start on artesunate. And a lot of them survived, even though the documentation of the history was grossly inadequate at that moment when I dropped into the wards. So what were, most deaths, that 70% occurred within the first 48 hours of admission. And that still underlines the fact that it is a dramatic illness. It is an emergency. And in the WHO protocols, you find that for management, it should be actually in an intensive care unit. But for us, we manage just at the ordinary wards. So within the first 48 hours, their mortality is high. Of the deaths, 4 out of 29 had prolonged hospitalization. So a few of the children with prolonged hospitalization will still die. that is 13.8%. So what were the factors associated with mortality in Blackwater fever? If you had a child coming with difficult breathing, and if the breathing is fast for the age, and if the breathing was deep sighing, that is acidotic breathing, or if the child complained of chest pain predominantly, or if the child had convulsions, or if the child had a delayed capillary refill, or if the child had severe pallor or has prostration. These are the associations of death. Next, please. Study number 4 was done by Dr. Asio and Masanja and Dr. Rio. And what they did was in response to the reports that had reached the Ministry of Health, the reports of increasing cases of Blackwater fever, particularly in the eastern part of the country. So Uganda National Institute of Public Health, that is what UNIPH is. The UNIPH bulletin of 2021 is where I got this study. So I picked it because it involved Soroti. Though in the title, you don't get Teso region, but what they did was to do the study in the 3 regional referral hospitals of the country. The aim was to confirm the reported outbreak and to generate information on the causative agent and to describe the cases in terms of person, place, and time. The outbreak investigation was launched at the 3 referral hospitals, as we already have alluded to. Next, please. The study type was retrospective, descriptive, case-controlled study. And the case definition was recent history of passing dark or red urine with any one of the following. So you just need the history with any one of the following: fever, anorexia, fatigue, abdominal pain, anemia, jaundice, headache, vomiting, and attending either, and they will have been attending either Soroti Regional Referral Hospital, Mbale Regional Referral Hospital, or Jinja Regional Referral Hospital during the period January 2029 to July 2021. The age group of children studied was less than 5 years. Next, please. I'm not sure about it. Continue, please. Next. Okay, so what were the results? 4,913 cases of Blackwater fever were identified in the 3 sites. Most of the cases, 65%, were from Soroti Regional Referral Hospital. So we just left the other 35% to be shared between Mbale and Jinja. So really, Soroti was the epicenter of this earthquake at that time. Males were affected more than females, just like we had cited from the previous studies, and 45% had experienced 1 to 2 episodes of Blackwater fever before. So recurrence is one of the characteristics of this condition. 70% of the cases had relapse every 2 to 3 weeks. So now this is difficult. This was difficult for me to understand. But if after treatment you come back within 2 to 3 weeks, you were taken as a relapse. And yet it's also true that you might actually be having the same condition which has not yet resolved. Because the resolution, like we took in the other paper, one of the factors of resolution should be stoppage of the intravascular hemolysis. The urine should be clear or normal color, grossly. But maybe some of these children had not attained really clinical clearance before they were discharged or before they went away. And then they might have come back within 1 to 3 weeks. I mean 2 to 3 weeks, and then they are counted as a relapse. So that's a bit of weakness on this point. It might just be that it had not completely cured. Because remember, in the days of chloroquine, when resistance was defined by the malaria control program of the Ministry of Health, if the patient had a negative blood smear, but after chloroquine, but then before 28 days, it is again positive and there is a clinical recurrence, then it is R1, resistance 1. Or resistance 2, if the parasite just reduced and the blood smear never actually went negative. Resistance 3, I mean 2. Then 3, if the parasitemia never even dropped down. So the resistance or failure of this particular treatment should be assessed after 4 weeks, after 28 days, not 2 to 3. So, but all the same, we had these children coming back within 2 to 3 weeks. All the case patients, because remember, this is a case-controlled study. All case patients had anemia, all of them. So one of the things we must respect this Blackwater fever for is anemia, because there will be anemia in all of them, all the children, or all the sufferers. All case patients had anemia. All cases and non-cases were malaria positive on PCR. Next, please. Only 55 of the cases were MRDT positive, but 100 of non-cases were MRDT positive. You remember the case here is Blackwater fever, and all of them have malaria, and they are comparing the two. I mean, they want to associate the Blackwater fever with malaria. That is why they chose the case-controlled study. And then they were able to make these conclusions or lessons that Blackwater fever caused substantive morbidity in eastern Uganda. That Soroti was the epicenter. That's my addition. It was not in their paper. That case patients experienced repeated episodes of Blackwater fever. And they suggested that future studies should focus on causes and triggers of Blackwater fever. Next, please. So the last study here, which actually is the oldest, That's why I think there should be other studies from Soroti, still from Mikri, or maybe other people as well. That study number 5 is authored by Professor Luputo Peter, Dr. Ngoru, and Professor Maitland Catherine. And the title is Renting Hospital with Severe Febrile Illness in Eastern Uganda. Okay, and you notice that it was published in 2017. And it was part unintended, not intended part of the feast and the expansion as supportive treatment. It was a multi-country, multi-center study, which surprisingly yielded high prevalence of Blackwater fever, particularly in Soroti. Of the 3,170 feast trial patients, 12.4 had Blackwater fever. 81% of them being from Eastern Uganda, predominantly again, Soroti Hospital. The other sites in Uganda, I think there were 3 other sites in Uganda, and then a site, yeah, and then another 1 or 2 in Kenya, another one in TZ, Tanzania. So it was a multi-country study. So this is the study in which it was surprisingly found that Blackwater fever was very prevalent. Next, please. Now there is a lot more which is done in that paper. I did not feel I didn't want to put it here because I'm not reviewing that paper fully. But one thing that impressed me is a section of prevalence of RBC polymorphisms among the patients with Blackwater fever. It was impressive because, those polymorphisms being HBAS, which is the sickle cell carrier, and HBSS, a sickler, and then alpha thalassemia, and glucose 6-phosphate dehydrogenase deficiency. So the study it was possible through this study for the people doing it to notice the prevalence of polymorphisms, RBC polymorphisms, and try to associate it with Blackwater fever. The prevalence, one of the findings, prevalence of HBSS was higher among the cases than among the community controls. Okay. So my question here is does it have a potential etiopathogenic role? That sickle cell SS status have etiopathogenic role in Blackwater fever? And one can imagine that, yes, as long as you have anemia which is getting worse,
Is Professor still on?
I see he's on the call. I just need to figure out why he's on mute. Meanwhile, his sound is not audible. Just
let me get back to you.
It's back. Thank you very much. Someone called as I was speaking, and then when I was trying to stop them, then it all went off. So we've talked about the SS, the prevalence of SS, and then the prevalence of glucose-6-phosphate dehydrogenase deficiency, no association, and then both HbAs and homozygous alpha thalassemia were associated with protection from Blackwater fever. And we all know that malaria belt is the same as sickle cell belt and is attributed to AS being able to survive in the malaria, within the malaria belt more than the AA. And then, of course, now there is also alpha thalassemia, homozygous. This one should also be protective, or they would survive better in a malaria situation. So those were the two important findings that I gleaned from that study. Next, please. So that's the end of the 5 studies that I was able to gather and summarize. Now, what would be the cause of Blackwater fever? We've already alluded to it, but at the turn of the 19th, 20th century, 4 theories on the causation of black fever were intoxication by quinine, because quinine was then being used, and there was already a lot of Blackwater fever. Then malaria itself, then consequences of previous malaria infection, and an agent different from malaria. But malaria eventually was found to be an essential great ingredient of Blackwater fever. Of course, we have already talked about John Eastman, Farrell, the Creole, but also the geographical coincidence between malaria and the malaria incidence or prevalence and the Blackwater fever. When the prevalence is high, Blackwater fever is also high. So that helped to at least coin the etiology. And then, of course, constantly, malaria plasmodium is demonstrated in the blood of people with the Blackwater fever. That is, if assessed before the attack or onset of Blackwater fever. Next, please. Cases of Blackwater fever were also described during the so-called malaria therapy used to treat neurosyphilis. I found this one very interesting and pitiful. That people, of course, it's true that the syphilis germ is very susceptible to heat, and should temperature rise in the body, it will die. So patients between 1920 and 1950, before penicillin was made, were treated with the malaria. The syphilis patients were treated with malaria. So even those patients who are treated with malaria actually some of them got Blackwater fever. So this is part of interesting history about Blackwater fever. Although mainly observed with malignant malaria, Blackwater fever also has been found to occur in non-falciparum species from the severity, and was independent. That was independent from severity of the disease and the level of parasitemia. So when we are dealing with non-falciparum malaria species, the parasitemia doesn't need to be heavy, neither does the child or the patient need to have severe disease. It can be just mild disease or even asymptomatic, and then they get into Blackwater fever. However, malaria alone does not induce Blackwater fever, as again shown by unfortunate experiment with Plasmodium falciparum inoculated into psychiatric patients. They were not, they could not demonstrate Blackwater fever in such patients. Who did not have other factors. Next, please. Now, one of the interesting pieces of information is that there is gene association. There are gene associations of Blackwater fever. We all know glucose 6-phosphate dehydrogenase deficiency historically. Though the study of those of Professor Lupo didn't show it, and many other studies have not shown it. But other studies are looking at a number of polymorphisms of the same gene, other polymorphisms that had not been described, and they are finding association. So glucose 6-phosphate dehydrogenase polymorphism or abnormalities of that gene are associated, but not fully. It is still an area which is being described. Haptoglobulin is also has some association. If there has been a change or polymorphism of that gene, it influences how fast the body clears the HB, how fast the body clears the hemoglobin. And then hemopexin gene, if there is also polymorphism in that gene, then there is a problem with the clearing, with the protecting the patient who has hemolysis, protecting them from the heme group, which heme group is toxic to the body. MBL2 phenotype, that gene, the gene MBL2A genotype produces high levels of MBL, a protein causing severe disease. So when this gene is found in a person, if people are screened for this gene, finding of such a gene will indicate that the patient is in danger, or the person who has that gene polymorphism is in danger of getting severe Blackwater fever. So is hexose 6-phosphate dehydrogenase or stroke glucose 1 dehydrogenase gene polymorphism. Why? Because this enzyme coded by that gene influences susceptibility to oxidative stress, which will, of course, increase hemolysis. Myoglobin gene, myoglobinuria can cause kidney damage on its own. So it can be additive or a differential of Blackwater fever. Next, please. What are other influencers? There are actually many. Even the major histocompatibility complex does influence. TNF alpha does influence. Level of complement receptor 1 also does affect severity. So there are many influencers of the severity of Blackwater fever. Next. This we all know, epidemiology of Blackwater fever is the most prevalent. It's most prevalent in sub-Saharan Africa and Southeast Asia. The common factor between these regions being endemicity for Plasmodium falciparum malaria. Was brought to publicity. We've already mentioned this, that Blackwater fever was published first in Africa when Blackwater fever was described in European soldiers, explorers, and administrators during the scramble for Africa. Cases generally reduced when chloroquine and sulfadoxine, pyrimethamine replaced quinine. And then Blackwater fever showed up again in the 90s when malaria resistance to chloroquine emerged. So we have already said about this slide. Next. Resurgence has been documented. We have seen the publications, and individuals with increased susceptibility and non-immune immigrants and individuals living in malaria endemic areas, especially children. And that's what that is our biggest factor in Soroti. Blackwater fever rarely appears until a person has had at least 4 attacks of malaria. So this is one of the points that incriminates the immune response to malaria. An immigrant from non-malaria area needs to live in a malaria endemic area for at least 6 months before they develop Blackwater fever. Next, please. Next, Moses.
Dr. Chor, are you still on?
Okay. So from those studies which we have seen, the age most affected below 12 years, making nearly 75% of the total cases. So at least 75% of all cases of Blackwater fever are children. And renal failure or AKI happens in 38 to about 50% of the slides are off. The slides are off.
Just a minute.
Yes, Professor, our time is getting up. Maybe we can increase on the speed.
Yeah. Most of these ones now, most of these slides have actually been covered in the studies description. So, yes.
Okay, Professor.
Yes. Yeah, so just go on, Dr. Chora. Just flip. So pathogenesis starts with the insult, which is usually malaria, as we say. And then there are the triggers. Those ones are also well established. And then it involves the immune system. The drugs have been like quinine, also triggers. Next. Predisposition triggers massive intravascular hemolysis, hemoglobinemia and hemoglobinuria, and then acute renal failure. That we've discussed. Next. The key clinical features, we all know, often high fever, but fever is not 100%. Sudden passage of dark or tea-colored urine or color-colored, rapidly developing anemia, prostration, jaundice, abdominal pain, vomiting, reduced or normal urine output. Normal urine output often masks renal failure. That's my problem, one of my problems with the Blackwater fever. It can give you normal urine output, and that might cover or mask renal failure. Mortality rate is high, necessitating urgent medical attention. But you see in the studies around Soroti, our mortality rate is less than this. Next. Take home. Blackwater fever has been endemic here in Soroti for more than a decade. Blackwater fever presents more often in older children with passing blood in urine. Presentation is dramatic and emergency, life-threatening. Quick referral is important. Severe anemia and renal failure are the two giant complications. Blood transfusion and IV attesinates are the two main interventions, thanks to Uganda Blood Transfusion Services, but severe renal failure requiring renal replacement therapy is a big gap. Next time, this is the end. Next time, I would like to be able to document for you the number of children for whom we need renal replacement therapy for survival from Blackwater fever. I will do that sometime and then come back to you. Thank you very much, Chair. Over, back to you.
Okay, thank you very much, Professor. I think we shall have a few questions. Many of them are already on the chat. So I will read some questions on the chat and you can quickly respond to them. I'll give you the first one, the risk factors for Blackwater fever. I think this has been covered. Study 5 brings out among the few things implicated in intervascular hemolysis, but how far they reached, I don't think this is a question. May you talk about the management of Blackwater fever? I think this is similar to the last question. Is there a protocol guide now at the region for Blackwater fever management? What is the experience of the children with persistent hemoglobinuria over 7 days? And maybe we can take those two questions and I'll read the others later on, Professor.
Okay, thank you, Dr. Chora. Am I audible?
Yes, we can hear you.
Am I still audible?
You're loud and clear.
Yes, I'm not sure about the question. Most of those questions, I'm not very. I didn't look at the questions before. Something about IV intravenous hemolysis.
I can read for you.
What is the question?
So I am going to read the questions. Many of them are related. The first is, what are the risk factors for Blackwater fever? And I think this was captured in the course of the discussion. It came during a bit earlier. May you talk about the management of Blackwater fever? And it is related to a question that says if there are guidelines or protocol for management of Blackwater fever in the region, and what your experience is with children who have persistent hemoglobinuria across 7 days. And then I will give a final question, and then we will answer, then we shall come back later. Is renal failure the commonest cause of mortality? And what is the conclusion on the use of steroids? Maybe you can take those, then I'll come back and read another set of questions.
So the conclusion on use of steroids not useful, no advantage over non-use of steroids. Of course, all drugs are poisons, and we should not use drugs when the advantage is unclear. That is one, but there is a space for us to do the ideal assessment.
Recording in progress.
There is space for us. There is an argument for us to do an RCT, and the argument is in cases, in individual cases, most of the individual cases of Europeans who got Blackwater fever, when they went back to Europe, they actually used steroids, and all of them showed dramatic or apparently dramatic improvement. But of course, that's not final because those are 1-1 cases. That is the reason why we try to take this first step. First, assess if there is any usefulness using retrospective data. But if and when we are able to do an RCT, then we'll be able to definitely say there is none. But it will be a tug of war to justify it with a number of recs. That is the ethics committees. It will be difficult to justify, but I think it can still be justifiable after a good space of argument. So steroids, no reason to use them, but we can still continue research. Cause of what? What the cause of?
I think that was a major question. The rest were covered during the course of the presentation.
Management of Blackwater fever is definitely to treat the malaria, and treatment of the malaria is according to the Uganda treatment standard treatment guidelines. Artesunate, and then after artesunate, you can give, when the patient can give diatem. Okay, because this is severe malaria, and please manage it as severe malaria. If you forget the diatem after artesunate, then you have not managed properly. And it's very, very common observation. People just say that this artesunate IV at 0, 12, and 24, they call it, he has taken the dose. That's not the dose even of artesunate. That's just 1 day of treatment. There are other days to cover if you are to use only artesunate. But that being a long case, it probably makes sense that we should use the diatem after the artesunate, but also give that artesunate according to the schedule. And very often, when we keep these patients in the small clinics out there, we end up giving artesunate once a day. And then this condition is rapidly evolving. The anemia comes to overtake and heart failure comes on. Oh, so what is your experience in managing Blackwater fever? The experience. Pardon?
I think emphasis was those with persistent hemoglobinuria.
Which have also been strongly rejected.
Now I'm not. The transmission is poor. You think it was hemoglobinuria?
Are you able to hear, Professor? The question is, what management? What experience the children with persistent hemoglobinuria over 7 days?
Over 7 days, you will the hemoglobinuria or dark or red urine will usually continue for about 3 days in the hospital. For about 3 days, Usually after 3 days, the urine has more or less cleared. But there are some patients, about a fifth of them, whose urine just becomes pale red. You know, it's not the straw-colored normal urine, but pale red. And those ones are still hemolyzing. And unless we take note of that, we are bound to discharge these children when they are still hemolyzing. And that is probably why that other group of patients were said to be having a relapse before 28 days. It is not a relapse most often. It is premature discharge of patients, and then they are partially treated. Hemoglobinuria was still there. But usually my experience is beyond 10 days, no gross hemoglobinuria.
Okay, thank you very much, Professor, for those. Our time is running out. I'm going to request that we could stay on for just an extra 5 to 10 minutes. And I will read just two very important questions, and I will open it up to the chat. I mean, for people to maybe speak. The first is from Medrin, who says, what's the best pre-referral treatment, especially if encountered by a nurse? And I think that's extremely important. And the second question is from Dr. Mukisa, who says, if patients are hemolyzing beyond 10 days, and by the time they come, they've already completed their oral antimalarials by day 5 or 6, should we continue with antimalarials as long as they're going to hemolyze? I think if Prof takes those two questions, I can open it up. Or maybe a final one from Dr. Epowat. Is Blackwater fever incidence or prevalence declining with availability and no use of artesunate, let alone outcomes? Professor Dit, those are quite a couple of tough questions for you.
The last one is, Dr. Chora, repeat the last one.
Is the incidence of Blackwater fever or the prevalence declining with the availability and or the use of artesunate, let alone its outcomes?
Okay, thank you very much for that, Elder Dr. Epworth. The prevalence is not reducing, to my impression. For this presentation, I'd wanted to more or less repeat what the data we had collected last year for the paper we published, but time caught up with us. But already there were more than 500 cases when my data person had covered only 4 months. So that means the prevalence is still high even this year. Last year, as I said, we saw 889 patients over a year. That is a lot. So despite artesunate, there is still, the prevalence is not reducing. And it might be that we are still using quinine in the peripheries because it's not off the treatment guidelines in the country. We know that its removal, complete removal, was responsible for reversing the previous outbreaks. But quinine is still around in the communities. And also, our artesunate, the treatment is for 7 days. So you are likely not to comply if people persist on using the injectables instead of turning to oral as soon as the patient is able to take, so that you try to prevent failure to complete the treatment. So if the other question is, if after 10 days of treatment and you have finished that TESNET course. But for this one, the most important thing is to make sure you check for malaria. Make sure you do the MRDT and the DS. If the MRDT is negative, DS is negative, most likely this is cleared. And you may have just to deal with the anemia, which might still be there. Anemia might linger on from immunologic response. So when will anemia, when will hemolysis stop? It's not guaranteed. In particular, patients might linger on. And we also know of patients who have had even 20 transfusions. At least Professor Olupoto has that story of a patient whose transfusions were very many in Mbale. But also here in Soroti, we've had up to 12 transfusions ourselves on particular few patients who continue hemolyzing. But when they are over the storm, they recover completely. So what is the best pre-referral treatment? The best pre-referral treatment is actually a TESNET. When you have made the diagnosis of malaria, you give an IV a TESNET and note the time when you gave and help the patient to come to the hospital one way or the other. Because don't keep that patient there, because you know hemolysis happens in all Blackwater fever patients, and the hemolysis might just overcome recovery, and the patient's HB will go down quick and renal failure sets in, and the patient may succumb just with delays. Thank you. I think that is it.
Thank you very much, Professor. Our time is fast spent. I will just allow James Opio to unmute and ask a question, and I think we shall tie it up here, colleagues. And based on the response this has gotten, I think we may need to have a few more sessions like this. But James, you can unmute yourself and ask a question.
Thank you so much, Professor Amos. James Opio is my name. I'm a radiologist. Throughout the discussion, I kept wondering whether there might be a role for imaging. But from the presentation, and especially one of the studies, where the observation was that 70% of the deaths occurred within 48 hours. And then they also conclude that the factors associated with mortality were chest pain, difficulty in breathing, and fast for age, respiratory rate. And all this occurred in the background of, I could imagine, standard interventions, i.e. blood transfusion, IV TESNET. My question is, are we missing something cardiopulmonary that imaging could probably pick? I'm talking about things like non-cardiogenic pulmonary edema, things like ARDS, or even probably opportunistic or seemingly innocent bystander conditions like pneumonia. Just making a case for imaging in that case. Thank you.
Thank you. That is brilliant. I think you are just educating us. You're reminding us. You're expanding the scope of learning, and reminding us that it is important to think of those things, those differentials, as we see these patients. So certainly, chest pain is bad. When these patients are in much pain, the prognosis is usually bad, and people should run. And I would be happy with a quick chest X-ray and others like ECG and so on. Difficulty in breathing, certainly you're right. It can be non-cardiogenic causes. So I really don't think I have anything to add, Dr. P. It is it is up to us to do more studies, actually document what happens in these patients, even preliminary studies. If the preliminary are positive, then we can go on and do other things. Even a case report can help us do bigger studies on these areas that we are not tackling right now. Thank you. Back to you, Chair. Moses.
Thank you so much, Professor Did. I think Moses is experiencing some technical issues. However, as he had stated, the session has been very, very wonderful and expertly led, especially hinged on research, local research, which we are encouraging people to do. I'm Dr. Ouma, the previous chairperson of the branch, and I want to thank you so much, Professor Did, for taking the time and gracefully presenting, but also answering our questions. I think that what you've raised is quite key. The takeaway points have been on the pre-referral management, which is very clear by any cadre, and also the in care as the child or the children continue in care with us, even beyond the normal time lag. So the importance of the research is to showcase that there are some things that are useful and are not. And then the ball is still in our courts, in case possibly to continue doing research, to answer more queries. So thank you so much. Thank you, the currently BEC team of UMA TESO, led by Dr. Dakun. And thank you, the chair CPD, Dr. Okello Simon. Let's meet again in 2 weeks' time on a Monday for the next topic. The CPD points will be awarded. Thank you so much, Professor Dean, and all people who have attended.
Thank you so much.
God bless you.
Bless you.
Amen.
Thank you, Dr. Ouma. Yes, you have something to say?
Good night.
Good night. Thank you.
All right.
Bye-bye.
Good